In this video from myself and colleagues at McMaster University, we describe the development of a retropubic TVT simulation model and its use via a clinical teaching video for OBGYN residents. The objectives of this video are to provide background clinical information on the relevance of TVT insertion skill learning and the benefits of simulation for this surgery. We will demonstrate the use of the TVT simulation model in a teaching video directed for OBGYN residents as a part of our future research study. Stress urinary incontinence is the involuntary leak of urine with increased intraabdominal pressures, such as when coughing, laughing, or sneezing. Prevalence estimates range between 10 to 55% among females aged 15 to 64 years old. Risk factors include those that weaken the pelvic floor. Evaluation for SUI includes a focus history, physical examination, and ruling out voiding dysfunction with a post-void residual. As this is a quality of life issue, acceptability of various treatment options depend on the risk-benefit profile for the patients. Expectant management, pelvic floor physiotherapy, pessaries, and various surgical managements are available. The number one surgical standard of treatment of SUI, given in large part due to its high success rate and shortened OR time requirements, is the TVT. As the TVT insertion process relies on passage through pelvic spaces where there is an intricate condensed network of blood vessels and organs, there is a risk of hemorrhage and a 0.5% risk of iliac artery injury. Bladder and urethral injury are also possible risks. Listed here are possible post-op complications. The importance of proper movement of the TVT insertion trocar is essential, as this is a blind skill. Preceptors watching cannot see the path of the trocar, and learners may not be familiar with the path the trocar is supposed to take. This can create heightened anxiety and discomfort for both the preceptor and learner. We know from an abundance of literature that simulation can help with surgical skills. Also, discomfort with surgical skills has been shown to be associated with perceived inferiority in performance, resulting in less confidence in the skill. Practitioners therefore may not offer this skill to patients, placing the burden on those patients waiting for the surgery for specifically trained surgeons. We therefore sought to develop a TVT simulation model that was both affordable and easy to assemble. The total cost was under $100, with the majority arising from infrastructure material such as the pelvic model. Expired TVT kits were donated to us, and the tissues were simulated with modeling clay that could be reformed and reused. In this simulation, we demonstrate the surgical steps to residents using the created model. We start by demonstrating how to handle the trocar and insert the sheath, followed by proper placement and motions for placement of the sheaths. Confirmation of appropriate placement and tensioning will also be discussed. Tips will be given along the way from an expert surgeon.
So this patient already had her counseling done. She's in the operating room under an anesthetic. She is in lithotomy position and her bladder is empty with a Foley catheter in place. You could use the catheter introducer to deviate the urethra and the bladder away from the site of insertion. So we're assuming that the tunnels are already created. So we will start on the right side of the patient with the urethra and the bladder deviated to the opposite side, holding the TVT on top with a proper grip to avoid having the tissues try and push your hand sideways, so you're in full control. So we'll start by going into the right tunnel of the dissection. Throughout the insertion, your index of your non-dominant hand is pinching the tip of the trocar between the patient and your finger. So you're holding it tight and guiding it, making sure you're not perforating through the vaginal tissue. As soon as the tip is right under the inferior pubic rami, you keep your finger there pinching your trocar so it doesn't go in further, and you immediately drop your hand to change the angle. The idea is hugging the bone with the TVT insertion. The closer you hug the bone, the less likely you are to perforate the bladder, which is represented here with the styrofoam. And you can see that the trocar is really hugging the bone. You're not aiming lateral because then you can get blood vessels or nerves, and you're basically aiming towards the patient's ipsilateral shoulder. Again, dominant hand is holding the TVT trocar and your finger is guiding. So we are passing it through the dissection. My finger is pinching the trocar against the inferior pubic rami. As soon as the tip passes the inferior pubic rami and it's going through the urogenital diaphragm, immediately you drop your hand. Very important to make sure that the trocar is behind the bone before you drop your hand. Otherwise, you're going to place it in the labia. And it's coming out, hugging the bone. And this is exactly where you want it to be, around 1 to 2 centimeters off the midline, completely hugging the bone, away from the bladder, away from the urethra, which is in the middle. Of course, at this point, you take the catheter out and you do a cystoscopy as well as a urethrooscopy to ensure that there's no bladder or urethral perforation. You will start by pulling both sides of the trocar out, making sure that the mesh, as it goes in, it doesn't twist. You want it to sit nice and flat, and you will keep pulling until the plastic in the middle here separates. I use a Medsam bomb scissor, which would sit here as you tighten to make sure you're not tensioning it, because if you do that, it will put the patient in urine retention, and that is not how it works. You're basically just creating a platform to sit under the bladder neck. I'm pulling, and you can see how we leave a bit of space between the urethra and the TVT. Once that is done, you can cut the plastic off.
Strengths of the model include its low cost, reusability, and ability to simulate muscle movements for the insertion process. Though the model does not teach the suburethral dissection or tensioning steps, this can be taught in vivo. Finally, we will be conducting a research study to validate the model's usefulness in helping resident performance and comfort with this surgical procedure.